All right, good morning, everyone. We are going to go ahead and get started. My name is Dana, and I am the Communications Specialist in Provider Engagement. And I want to thank you all for joining us today for our annual Provider Update webinar. We have a lot of information to cover today, but before we get started, we are asking that you place your questions in the chat box, and then we will address them after each speaker. Also, we will be giving away 4 gift cards today. So if you can stick around until the very end, you just might be a lucky winner today. All right, so without further delay, I would like to introduce our first speaker, William C. Fiala, who is a professor of practice at the School of Allied Health, the College of Health and Human Services at the University of Akron. Take it away, Bill.
Well, thank you for the opportunity to speak. And thank you for listening to me this morning. We have a brief topic this morning, and that's reporting well visits with and without abnormal findings. So let's go ahead and get started with looking at that topic. And as we begin, let's step back and talk about coding generally, how important it is, the story it tells. On the right side of the slide here, you see just 18 digits. This is typically all a payer knows about what happened, these 18 digits. But pause a moment and understand the information that those 18 digits convey. And you see it there on the left. This patient was admitted to the hospital by the surgeon. Within 24 hours of that admission, patient went to surgery. An appendectomy was performed. The appendix was ruptured with an abscess. Nobody from anesthesia was available. Maybe we're at a rural hospital. So the surgeon had to provide his or her own anesthesia services. When the patient was opened up, the surgeon found an altered surgical field, maybe a lot of adhesions or some altered anatomy. And the surgery required more than the typical service for that procedure. All of that information is conveyed by just those 18 digits. That's a lot of information that's conveyed by 18 numerals. There's no need for the provider to ask for any records. There's no need for any additional paperwork to be sent. That's how important the coding is. Our discussion this morning is going to veer more towards the diagnosis code side. So let's look at an example there. And that's what you see on this slide. On the right, there are 23 characters, mostly numeric, some alpha characters. And again, take a moment and think about what those 23 characters convey. This patient fell out of bed. The fall resulted in a concussion, no loss of consciousness. But the patient does now have an abnormal EEG and spasm-induced angina. And this is the initial treatment for all of that. That's what those 23 characters tell you. Again, all of that is conveyed just by what you see on the right side of the screen. So again, this sort of sets up the discussion of why the coding is important. Recall those recovery audit contractors. begins at the RAC auditors. That begins as a pilot project about 20 years ago. It did really well. That is, it did really well for the federal government, and it becomes a permanent program. The RAC auditors use two levels of audit. The first being automated, and that's what should have our attention. Most carriers, most non-governmental carriers, use some sort of automated review process for a number of different purposes. And I want you to keep in mind AI. We read about AI all the time in the newspaper. Also think about medical necessity. Medical necessity is often predicated upon matching or pairing diagnosis codes and procedure codes. You want the story your coding tells to be complete and without contradiction. And importantly, you want any automated review to be a non-event. Now, let's shift to the specifics of our discussion this morning, given that general overview of coding. Diagnosis coding for well visits will typically come down to one of two pathways, with or without abnormal findings. And you see the pairs of codes here on the screen for adults and then for children. And you see that Z00.00, the general adult medical exam without abnormal findings, and then the last two characters, 01, with abnormal findings. And then you see a similar pair of codes at the bottom of the slide for children with abnormal findings and without abnormal findings. Oddly, the code set reverses the order for children. When you look at the Medicare annual wellness visit and that initial service, these are the codes that will be used for that. When you follow the guidance from Medicare, there's actually a fairly broad range of codes, that Z00 to Z09 range. But materially, you are in fact going to use these with and without abnormal finding medical exam codes. And that's the guidance that the code set gives you. That's the guidance that Medicare gives you for the annual wellness and the initial welcome to Medicare visit. So, with that in mind, what constitutes an abnormal finding? What is an abnormal condition? To define that, start with what the authors of the code set, the cooperating parties that constitute the authors of the ICD-10-CM code set, start with what they tell you in the guidelines. And they point to two things. If you look at the official guidelines for coding and reporting, and you'll find those in the beginning of your code book, they point to two things. The first is if you, provider, you, clinician, have the patient in for what is expected to be a routine preventive service, and during your exam, you find something new that isn't right. Say you're palpating lymph nodes here or here, and you find this enormous lymph node. It's new, and it's not right. It's abnormal. That's an abnormal finding. Alternately, you have a chronic condition that has a change in severity or an acute exacerbation, that's an abnormal finding. So something new that's not normal, or a chronic condition that has a change in severity or an acute exacerbation, those, according to the authors of the code set, are abnormal findings. Second bulleted item is a citation from the AHA Coding Clinic, which essentially tells you the same thing. The AHA Coding Clinic is noteworthy. It is the quarterly publication from the authors of the code set, from the cooperating parties that constitute the authors of the ICD-10-CM code set. It's sort of the diagnosis coding equivalent to CPT assistant on the procedural code side set. And it tells you again, essentially the same thing. Now, a chronic condition that is not experiencing a change in severity, is not experiencing an acute exacerbation, that is not an abnormal finding. It would not be reported as an abnormal finding and would not be reported with the abnormal finding code. And you see an example here on the slide. Note the citation here. It's from Family Practice Management. That's the publication by AAFP. So this is the family practice folks telling you this. And if you look at the date, this is easily a decade ago. So this really isn't news. Similarly, in addition to the example that you have here, if you think about a patient with diabetes, they already have an abnormal blood sugar. They're going to have an abnormal A1C. If the values are essentially at the patient's baseline and they're not experiencing an acute exacerbation, they're not experiencing a change in severity, that should not be reported with an abnormal finding code. Similarly, a patient with hypertension, they're going to have a systolic pressure greater than 120, might be in the 130s, might be in the 140s. If the patient is regularly there, if the patient is not experiencing a change in severity from that patient's baseline, if the patient is not experiencing an acute exacerbation, you're not going to report that with an abnormal finding code. Recall that preventive services, including the annual wellness visit, inherently include an inventory of chronic conditions. So, absent a change in severity or an acute exacerbation of the chronic condition, that inventory and the recording of current ongoing treatment regimens is part of the preventive service. This really isn't news. This isn't some new revelation. Stepping outside of the annual wellness visit, you can find the same information in the AAPC journal. If you're not familiar with AAPC, it's one of the two national entities that certify coders. And they published essentially the same information over a decade ago. You can find the same communication from the family practice folks. And if you look at the citation, they told you essentially the same thing over 2 decades ago. So when the plan part of the encounter note reads, continue the current therapy, or renew prescriptions for the chronic illness, and or it shows cyclical labs that are typical to their chronic condition, that's not rising to the level of abnormal for purposes of the coding here. And these ideas transcend to the procedure code side. The threshold to report the separate CPT code is fairly high. And that's what the authors of the procedure code set tell you. That's what the CPT authors, the American Medical Association, tell you. Their threshold is significant and separately identifiable. Similarly, the family practice folks told you that again a couple decades ago, second bulleted item there. And at the bottom, carriers have been telling you the same. Here you see a citation from the TRICARE folks in about 2009. In pediatric medicine, the threshold to abnormal for the diagnosis coding seems a little lower, and you can read through the citation here on the slide. Two thoughts on this. First, note that the discussion here dates back to 2015. That's the year that we transitioned from ICD-9 to ICD-10. So one does wonder whether this isn't part of the transition. Second, note that the pediatric folks do tell you this still doesn't justify this separate E&M service. And they emphasize that in their question and answer. If you look at the citation here, even though it's an abnormal finding by their little looser definition, that does not automatically connote to a separately reportable E&M service code. So let's summarize where we're at here. If you have a well visit wherein no abnormality is detected, no new abnormality is noted, and the patient either has no chronic conditions or chronic conditions with no change in severity or no acute exacerbation, then you're typically going to report that Z00.00 for adults or the Z00.129 for children. That encounter will include inventory, reevaluation, prescription renewal for chronic conditions for which there's no change in severity or no acute exacerbation. It may include management of insignificant problems. And you're really going to have a challenging case for reporting a separate E&M code. That's going to be an uphill struggle in that circumstance. A well visit wherein an abnormality is noted, something new and not normal is noted, or the patient has one or more chronic conditions with a change in severity or with an acute exacerbation, then you need to report that Z00.01 for adults or the 0.121 for children. And then you're going to need some ICD-10 CM code, some diagnosis code to indicate what that abnormality is. You're probably going to need a separate E&M code because you're going to need to manage that problem. Note in this discussion that the Z00.00 code reported for an encounter in which there is that significant and separately identifiable E&M service really doesn't make sense. And that loops us back to the earlier discussion of the automated audits. You need to make sure that your coding makes sense for those automated audits. And that's that discussion of, and you've heard it before, the provider being out of profile. That's part of that automated discussion, that automated audit discussion, because you don't want to be out of profile. And with that, I think the folks who are monitoring the chat might be picking up questions. Do we have time for questions?
And thank you so much, Bill. All right, are there any questions in the chat box?
Not at this time.
Okay. All right. So Bill's presentation does allow for one CEU credit. So if you need to receive the certificate, I would ask that you just please email providerengagement@summacare.com. And in your email, please let us know how you would like your name written on the certificate. Okay, next up, we have Essie Mueller, who will come and give us an update on the 2026 Medicare Advantage plans. Take it away, Es.
Good morning, everyone. I'm Essie Mueller. I'm a provider engagement specialist here at SummaCare, and I just wanted to take a few minutes to go over some of our changes for our 2026 Medicare Advantage plans. First up, we just wanted to show you one of our network coverage maps. This shows you the 33 counties that we participate with our Medicare Advantage plans. We also wanted to note that one of our plans, Topaz, which is a very popular plan, is expanding into 7 different counties, and you can see that on with the little white dots there showing on the map. So we are expanding that program, that plan program. Next up is what plans are we offering this year? We have 7 plans total. We are offering 6 of the same plans that we've had in previous years. So Amber is our Medicare Advantage only plan with no Part D coverage. We're offering Topaz again. Quartz will be new in 2026, a new plan for our members. Also, we have Garnet, Ruby, Sapphire, and Emerald. Our Jade plan will be discontinued at the end of 2025. Members will not be re-enrolled into another plan. They will have to choose a different plan at that time. All 7 plan options cover the same medical services that are covered by our original Medicare or traditional Medicare, both parts A and B. Give you a little more information on a couple of our plans here. Sapphire and Emerald are HMO plans that have a point of service option available. These plans offer both in-network and out-of-network coverage. Please keep in mind when a member goes out of network, they will have a higher cost share. Their copay may be higher going out of network. All Part A and Part B services are covered under the point of service option in these plans, but most of their supplemental benefits are only covered when they utilize a SummaCare network contracted provider. Our HMO plans that we will have available this year are Amber, Topaz, Quartz, Garnet, and Ruby. These plans offer an in-network coverage only. They have to see a SummaCare contracted provider unless they are in their visitor travel benefit area, then they can see a Medicare participating provider. The exception to in-network only would be, of course, emergency services, urgent care, as well as their routine dialysis. 2 plans we want to note to you that may be important for members signing up. Our Quartz and Topaz plans both have a $0 premium. That means the member will not pay any more monthly for these plans. Quartz and Topaz both have the same number of supplemental benefits, but Topaz has a more generous benefit in dental, vision, and over-the-counter. The supplemental benefits that are available on all plans are dental, routine vision and hearing exams, hearing aids, visual and travel benefits, additional telehealth services, silver sneakers, and our over-the-counter benefit. Our over-the-counter benefit does have a new vendor this year. It is going to replace Convey, and our Medicare Advantage members will be receiving a new and more debit card after the first of the year. We wanted to also note that there's some changes with our diabetic testing supplies. Only Abbott and Essentia Contour diabetic testing supplies are covered. Both of those brands are available through HomeLink or any of our contracted network pharmacies. Diabetic testing supplies from other manufacturers will not be covered, and diabetic shoes and inserts are only covered when they use HomeLink. We're going to be offering a new quality program for physical therapy. It's an online program called Sword Health. We just want to mention it in case one of your patients would bring it up. This program will be available to all Medicare Advantage plans. Sword Health is a digital health company specializing in musculoskeletal care. They connect members online with licensed physical therapists. The goal is to reduce pain, improve mobility. Hopefully, we can prevent some unnecessary surgeries as well as medications through the physical therapy they provide online. Participation in this new program is optional for the member. However, members must actually qualify for the program with a diagnosis, and SummaCare will be doing a year look back and watching for those diagnoses coming in to offer the program to the members. We wanted to mention, of course, our Medicare resources, where you can go and look up information. Plan Central, our online web portal, will continue to be your best source to check eligibility, benefits, co-pays, deductibles, co-insurance, claim status, retrieving EOPs, that type of information. There is many more topics on there, such as the supplemental benefits, as well as there are counters and limits listed there. So if somebody has already had their routine eye exam done, you can see it there. If someone has already had their annual well visit done, it will be placed on there once we receive the claims. There is also deductible information, and have they met their yearly maxes? It is listed there as well. We encourage everyone to use Plan Central, and if you're not already signed up on Plan Central, you can go to our website at SummaCare.com. There is a provider tab, and there is a section there that says request access for the portal, and you can just click on that and we'll start the process and get you a username and password. It is a 24/7 tool that you can use. It's self-service, and you could eliminate having to call us for a lot of the information you need. And lastly here, we do have some Medicare materials that we can make available to your offices. These materials are brochures and comparison charts that may aid you when you have patients asking questions like, what plan should I choose? Will my doctors be on this network? Will my pharmacy benefits, will I have the same pharmacy coverage? You can have them call us. And if you would want any of these materials in your office, you can reach out to provider engagement at SummaCare.com, and we will be happy to either mail or deliver some materials out to you to assist with your patients. And that is it for me.
Thank you, Essie. Are there any questions in the chat for Essie?
Yes, there is one. Are you following Medicare guidelines and reverting back to pre-COVID rules for telehealth by providers?
Yes, we are. We are following Medicare guidelines.
Any other questions?
Yes. The viewers would like to know if they're going to be getting a copy of the slides.
The slides will be placed out on the website, so that should be sometime around early next week. And you will be able to, if you go out to the SummaCare.com website, click on the providers link, scroll all the way down towards the bottom on the left-hand side, you'll see a link that says events and webinars. These slides will be placed there, and if you missed any portion of this presentation, the video recording will be there also. Okay, is that it? No more questions? All right, so thank you, Essie. Up next, we have Tiffany Marakovich, who will provide us an update on pharmacy.
Good. All right. Good morning, everyone. Tiffany Mrakovich, Director of Pharmacy for SummaCare. Just going to run through a few pharmacy updates for you this morning, some things to expect in 26. So we'll first touch on some Medicare-specific updates, looking at the Inflation Reduction Act and what changes that brings for 26, our pharmacy network, and some updates to our pharmacy benefit and formulary, and then just a reminder on our Medicare prescription payment plan. Then we'll go into a couple of our strategies we want to touch base with you on for 2026. So jumping right into the Medicare updates. First one to highlight what's changing in 26 from the Inflation Reduction Act. The $2,000 annual out-of-pocket threshold will update to $2,100. Continuing from 2024, once a member hits that catastrophic phase of the $2,100, they will pay no additional cost for their Part D drugs. The first 10 drugs have been negotiated by CMS, and that goes into effect 1/1/2026. So I've highlighted those for you: Eliquis, Farxiga, Stelara, Jardiance, Entresto, Novolog, Xarelto, Enbrel, Januvia, and Bruvica. The asterisks there on the Farxiga, Stelara, Entresto, and Novolog indicate that there is either the generic or a biosimilar also available on the 2026 formulary. While our network is staying the same, we have all the same pharmacies in our network, which is a broad network. We are now indicating that there are preferred and standard pharmacies. So the preferred pharmacies will offer lower cost sharing than our standard pharmacies for all tiers except for the tier 5 specialty medications. And then Walgreens is really the only standard pharmacy where the cost share will be slightly higher than our preferred pharmacies. So just to depict that, we still have Giant Eagle, Walmart, Klein's, Summa Health Pharmacy, Acme. All of your major pharmacies and our mail order are still preferred pharmacies. The only one, again, that will have higher cost sharing will be Walgreens. It touches about 3,500 of our 26,000 Medicare members. Want to touch base on the formulary. So we still have a 6-tier formulary, with tier 1 being preferred generics, tier 2 being generics, tier 3 is preferred brand name drugs with some up-tiered generics into that tier. Tier 4 are non-preferred drugs, tier 5 is our specialty tier, and tier 6 is select care drugs, which includes drugs that treat things such as hypertension, diabetes, and cholesterol. So those are offered at lower cost. They're also are the drugs really targeted for those adherence star measures that we focus on. So tier 1 and 6, those are both available for a 100-day supply for our Medicare members. Tiers 1, 2, and 6 are $0 for all of our plans now at preferred pharmacies. Vaccines actually were in tier 6. There's a little error on this slide. They were in tier 6. They are moving to tier 3. But the vaccines that are ACIP recommended will continue to be a $0 copay per the IRA. We do not have significant swings in our generic drugs being up-tiered into tiers this year, as we have seen the prior year. This probably looks kind of small to you, but this wanted to highlight some changes to our pharmacy benefits for the different plans. You can see we added Quartz along with Topaz. Those are 2 zero premium plans, and those have the highest deductible. So for this year, the deductible will apply to tiers 3, 4, and 5. And we have increased the deductible on some of the plans. So Topaz and Quartz have $300, Garnet $250, Ruby is $150, Sapphire is 50, and Emerald is 0. Then you'll see that they list cost sharing. The first number listed is at the preferred pharmacies for a 30-day supply, and then the number following will be at the standard Walgreens pharmacies for a 30-day supply. Also of note, we have changed Tier 5 to co-insurance this year for all plans, and Tier 3 is switched to a co-insurance for the Topaz, Ruby, and Garnet plans. I'm sorry, Topaz, Garnet, and Quartz plans. The insulin will be capped at a $35 copay for a 1-month supply, and the deductible does not apply to insulin. Tier 2 and 3 are covered at 2 times copay for a 90-day supply or at mail order. And Tier 5 will be limited still to a 30-day supply. Whoops. Oh. Back. Oof. Sorry, not sure. Is that the next one? Sorry, folks, technical difficulties. Okay, yeah, this is the right place. I want to talk about a couple of negative formulary changes, not significant changes hitting this year. This is by the RX count or by NDC practically. So there are a total of 442 RX that are impacted. Of those, 345 are the pen needles. So those will be moving from Tier 2 to Tier 3 for 2026. And then there are only 12 drugs moving from Tier 2 to Tier 3. So just wanted to highlight, while there are some changes, most of those will be impacting the pen needles, and that's something you may hear the members speak about. When we get to the drug level tier changes, wanted to call out a few highlights. So albuterol has a couple different manufacturers or branded products, and when there's a branded product, there's a specific generic product for each of those. So one of the branded products is moving from Tier 3 to Tier 4. 828 members are currently using that product. However, there is still an albuterol HFA from another manufacturer available in Tier 3. Of note, the total cost for a 30-day supply is only $47.89. So in Tier 4, the most they'll pay for that is 50% coinsurance after deductible applies. As I indicated, the pen needles will be moving from Tier 2 to Tier 3, as we're moving Tier 2 to a $0 copay. And the member impact is 544. The average cost we see for a 90-day supply is about $110. There are no alternatives left in the lower tier there. Also want to call out the budesonide fumarate inhaler is moving from Tier 2 to Tier 4, so that will be subject to deductible. We have 394 members taking that medication. The total cost for a 30-day supply is about $197. We do have fluticasone somaterol inhaler available on Tier 2 as an alternative for some of the members. And then the other one I wanted to just highlight is the insulin aspart. That is moving from Tier 2 to Tier 3, but keep in mind all insulins are still capped at a $35 copay for a 1-month supply. There are a few drugs we're removing from the formulary as well, so wanted to highlight those for you. A total of 24 that actually have utilization for our population. So Actemra will be converted to the biosimilar Tyene. Ajovy, we're now preferring Emgality. For Prolia, moving to the biosimilar Staboclo. And for Semglee and Tresiba, the insulin glargine YFGN, which is the generic of Semglee. Lantus and Trujeo will be preferred agents for the formulary. These members will receive letters to let them know of these changes and our alternatives that may be an option for them. We encourage them to speak with their doctor before making any changes or requesting a formulary exception. Also wanted to just run through a quick reminder of the Medicare prescription payment plan. This was a new plan program that was offered by Medicare in 2025. So This will work the member's current drug coverage, and it helps them manage their out-of-pocket costs by spreading it over the year. This program might help them if they have higher costs early in the year. It does not save them money, and it does not lower the costs of their drugs. Again, it just spreads the cost through the year. There's no cost to participate, and anyone with a PDP or a Medicare Advantage plan is eligible to participate in the program. So how does it work? If the member opts into the program, when they go to the pharmacy, they will not have to pay a copay. They'll just pick up their medications, and then we will invoice them monthly for their costs for the drugs spread out across the year. Of note, if they opted into the program in 2025 and they stay in the same plan, say they opted in and they're in Topaz, they will remain opted into the program into 2026. However, if they switch plans, say they move from a Ruby to a Topaz, they will need to re-opt into the program under their Topaz plan. So who's likely to benefit from the program? Really those members that have high cost early in the calendar year. And although a member could start participating at any time in the year, there's less months left to spread the cost out if they start late in the year. So this may not be a best choice for members that have low drug costs all year. Their costs are the same each month, or they're considering signing up late in the year. Or they're getting extra help or other assistance from other programs. And why this program might be important, I just want to highlight, is with the switch to a higher deductible and switch to co-insurance, members that, for example, take Ozempic on our Quartz or Topaz plan, their first fill will be $453 for a 1 month supply, and members may feel that they can't afford that. This program will help them spread that cost across the year. So just a reminder that this is an option for them. You can get more information at our website or the CMS website, provided both the links for you in the presentation. You can also direct them to call our SummaCare Medicare Member Services for additional information or to opt them into the program. Well, they need to opt themselves in, sorry. And that number is located on the back of their member ID card. Just a couple general updates, things I wanted to highlight. MedImpact is our PBM. We do use a Choice 90, Choice 100 optimization program with them. What this program does is identify members that are currently taking a 30-day supply of a medication, but they're eligible to fill either a 90 or 100-day supply. When that's identified, a fax will be sent to the prescriber of the medication for the patient and ask them to consider switching to a 90 or 100-day supply. The little image is an example of what that letter would look like when it's faxed over. So if that could be completed, faxed back to the pharmacy, then they would be updated with a 90-day supply. The benefit of the program is really the primary goal is to improve member adherence and patient outcomes. Tier 1 and Tier 6, remember, are eligible for a 100-day supply, and that really helps hit those STAR measures. If they just get 3 fills of a 100-day supply, then they are meeting that STAR measure. This can also lead to an improved MLR because our pricing is better when we use the Choice 90 or the mail order supplies. I also want to highlight our biosimilar strategies. The chart below gives you what the branded drug is, what our covered biosimilar is, which line of business it impacts, and if it's the medical or the pharmacy benefit. So we'll be making some moves this year to really try to convert some of the Humira to the biosimilars. You can see that the preferred biosimilars are different between our commercial and Medicare lines of business. We're already really pushing for the biosimilars for the Remicade and the Rituxan. And those are both covered under the medical benefit today. So this list is subject to change as new things are entering the market on a weekly basis. You can monitor our website for more updates on preferred products.
Thank you, Tiffany. Are there any questions in the chat for Tiffany on the pharmacy updates?
No, not at this time.
Okay. All right, so our next speaker will be Christy Johnson, and she will provide an update on utilization management.
Good morning, everyone. My name is Christy Johnson. I'm the manager of utilization management for SummaCare. And really today, what I'm going to focus on is highlighting our utilization management page on SummaCare.com and some upcoming changes to prior authorizations. First and foremost, we're really excited to announce and continue to communicate that we have started a new authorization system and a new authorization portal called Guiding Care. This will go live on October 20th of 2025. This is a brand new portal for our providers to be able to enter prior authorizations on any type of authorization that you are requesting. So it includes acute inpatient, skilled nursing facilities, uh, LTACs, outpatient procedures, pharmacy. We really took a lot of time to build this provider portal to make sure that the process of submitting authorizations is a lot more quicker and easier. For more information on this portal on how to register, you can go to SummaCare.com under our utilization management page. There's a separate sidebar there for the Guiding Care portal. On there, you'll find a instruction on how to register. You'll also find a PDF on a user guide. And we also created videos on how to submit for different authorizations. So if you want to know how to submit for a scheduled elective surgery that's pre-service, we do have a video on that. We have a video for pharmacy as well to submit for drug authorizations. And we feel that our providers will really enjoy and like this portal, find it easy to use. These requests then go directly to a utilization management nurse for review. If there are any questions on our website, we do have contact numbers if you have questions. If you're also a provider whose staff member needs to have access to multiple providers within your group, please reach out to Provider Services so that we can get that set up for you in our new system. Again, this will go live on Monday, October 20th. I do want to point out something that's not on the slide is that for Plan Central, for our portal authorizations that are currently on Plan Central. We will stop accepting portal authorizations on Plan Central starting Monday, October 13th. The reason that we're doing this is to ensure that we have a smooth and clear cutover so that we are not having authorizations submitted on that portal and then you're not getting any response back once we go into our new authorization system. So for next week, we will take all authorization requests submitted by fax. Our fax numbers are listed on our website. And they, I can give them to you real quick. They are 234-542-0811 or 234-542-0815. So you can fax to those two fax numbers your authorization request next week, and then we'll go live with the portal on October 20th. On our utilization management page, we do have, like I said, hours of operation. We have contact numbers. We also have several resource links for you to be able to try to have all the information that you need in order to submit a prior auth and or look at criteria for whatever request you are looking for. So for example, on our website, we do have our SummaCare department policies for utilization management. We also have our medical policies are listed there. So if you're looking for something like an LVAD and what criteria that has for an LVAD, how do we prove that? What are you looking for your member? We do have access to all those medical policies at your fingertips. We also here at SummaCare use InterQual for our criteria, and there is a link there for you to be able to launch into the InterQual portal and register so that way you can look at the criteria for other types of requests. We also have quick links for EviCore. So if you need to submit something to EviCore or go to their website, you can see that on our provider page, as well as Medicare national local coverage and national coverage determinations, because we do follow Medicare guidelines. We do have a quick link for that where you can log into the Medicare site and you can look up and see if there's any medical criteria that Medicare covers or does not cover. And as stated again, you'll also see the tab for the Guiding Care, which is our new authorization portal we just went over. One update that I do want to give that will start on Monday, October 13th, and that you'll start to see on our prior authorization lookup tool. The prior authorization lookup tool is on our provider page under the tab under prior auth. We are encouraging and asking all providers that before you submit a request, please check this prior auth lookup tool to, one, ensure that what you're requesting requires auth. And if it does, where does that authorization go? And are there any specific instructions for it? So for this, for ambulatory surgery starting on October 13th, there are some CPT and procedure codes that will be requiring authorization when it's done in an outpatient or inpatient setting. However, it will not require an authorization when done in an ambulatory surgery center. We are starting on January 1st of 2026 for our Medicare Advantage members. They will have lower copays for those procedures that are done in an ambulatory surgery center. The lists have been sent out by Provider Support Services already for the go live date of October 13th. Also, our prior authorization tool has been updated. So you can see here under critical instructions that it will tell you that this code does not require auth if done in ambulatory surgery center, but will require an authorization if done in an outpatient or inpatient setting. Couple of things that we just want to put out in regards to authorization requests and the information that we need. This is a list of information that if it's supplied to us, we are able to process the request and give a determination in a quicker fashion. If we have a lack of this information and we have to reach out, it does take longer to be able to process the request, and can also lead to and end up in a denial. So things on this list would be obviously physician notes that support the request. If you have any consultant notes, things that are important like members' vital signs, if you're sending for acute inpatient, the medication list for the members. If it's something for skilled or rehab or LTACs, the physical therapy occupational notes are very important. If you're an out-of-network provider, we also ask that you provide the reason why the member needs to be seen by you as the out-of-network provider. This will help in our investigation and further determination. Lab results, and another two big things that we see missing is whether your request is for inpatient or outpatient. We do see on some of the prior auth forms that both are checked. And when both are checked, we do have to reach out to you as the provider to determine which status you are actually looking for the patient. The other piece of information that tends to be missing is the direct contact information. If we have someone that we can directly reach out to either request additional clinical, or if we have questions for you as the provider, this will help us save time if we're able to speak to someone directly. And that way, again, we can process the determination in a quicker, faster method. So we talked about some changes for ambulatory surgery starting on Monday, October 13th. We also have some changes for EviCore in regards to two programs, musculoskeletal and cardiovascular programs. So a notice was sent out to you as the providers this week in regards to these two programs. We also have this on our SummaCare.com provider utilization management page under prior auth, where you can find this program CPT code lists. And what it is for cardiac implantable devices and vascular intervention. You can begin submitting auths for those CPT codes to EviCore starting 11/24 of 2025. For dates of service of 12/1/2025 and after. For musculoskeletal pain management, joint and spine surgeries, you can begin submitting those CPT codes that are on that list to EviCore starting 12/15 of 2025 for dates of service of 1/1/2026. So again, if you have any questions, please don't hesitate to reach out. And we have provided the code lists for each of these programs of those codes that will also go to EviCore. We have also will be updating our prior authorization lookup tools. So again, we encourage you to look up that CPT code to determine, does it come to SummaCare to process, or is this a code that goes to EviCore? Evacor will also be following that ambulatory surgery list. So they will also have those that if it's done in an ambulatory surgery center will not require prior authorization. And just a few things to highlight that Evacor does process for us. They do process high-tech radiology, medical and radiation oncology, lab and genomic testing. And then again, the two programs that I just mentioned and went over is the musculoskeletal pain management, joint and spine, and the cardiac implantable device and vascular intervention. Those are the types of requests that go to Evacor. And again, our prior authorization tool will also help guide you. We also have put into place into our guiding care portal that if you submit a CPT code that goes to Evacor, it will provide a pop-up to you on the portal that tells you that this request or that CPT code needs to go to Evacor. So then it does give you the ability to then launch into the Evacor site so you can continue submission of your request. Or it also gives you the ability to continue forward to send it to SummaCare where we can evaluate whether or not it is truly something we would authorize or if it's something that needs to go to Evacor.
Hey, thank you, Chrissy. Are there any questions in the chat regarding utilization management?
Yes, there is one. Actually, there's two. Does any of this apply to ambulance transports?
No, it does not.
What was the date again for Evacor and vascular intervention?
The date for the vascular is going to be, let me pull this, I believe I can. Evacor will start taking the request for the vascular on 12/15 of 2025 for any procedures that are 1/1/2026 and after. So if that request and that surgery is going to be after the first of the year, you can submit those requests on 12/15 to Evacor.
That's all.
All right, thank you. So once again, if you missed any portion of today's webinar, the slides will be posted on our website at summacare.com. You will click on the providers link and then provider events and webinars. Also, if you maybe have a question that you did not think of while we were here today, please email your questions to providerengagement@summacare.com. All right, so the moment we've been waiting for, we have now arrived to the gift card giveaway. Like I said, we're going to ask that you put a number in the chat box between 1 to 10, and then the first 4 people who guess the correct number will win the gift cards. So I'm going to have, while you guys are doing that, I'm going to have Essie Mueller come and pick a number out the box. Okay. Number 2. Do we have any 2s in the chat? Okay, you guys mind reading off the names of the winners if possible?
Yvonne Banks.
Right, congratulations, Yvonne.
The year, right here. There's another one here. Oh yeah, Kimberly.
All right, we're checking.
The next winner is Kimberly, no last name.
Okay, Kimberly, are you able to put your name in the chat box for them so that we can make sure we get the certificate, the gift card to you? I'm sorry.
Winner is Michelle Brewer.
Michelle, congratulations.
So there is a Kimberly, another Kimberly, or there are 2 Kimberlys with the last name HERMANOWSKI.
Okay, Kimberly Hermanowski. Is she the one that entered the four? Okay, it's not her. Is it someone else? If you can, put your name in the chat box. Okay, they are trying to figure out who this last winner is.
Winner I show is London Minor.
London Minor. All right. Thank you so much. Congratulations to all of our gift card winners. Once again, thank you for joining us today. Someone will reach out to you to determine where you would like us to send that gift card. We thank you all. Like I said, once again, we hope you have a wonderful day, and we will see you again here next year.
3.